My talk's not going to take the whole of my time, so I'm just going to actually start by picking up on one of those questions that didn't get answered just now, which was atrial fibrillation and stress echo. I think we should all be honest and acknowledge that atrial fibrillation is a bit of a nightmare and a headache for all of our non-invasive modalities. The year before last, I asked our fellow in Southampton to look at the evidence that supports the use of all of our stress modalities in AF patients, and the truth is there is unbelievably little evidence. It's very difficult to know what to do with these patients' beta blockers, for example. If you keep them going, there's a very good chance that they will either not achieve target heart rate or you'll have a false negative test, and if you stop them before the test, they might turn up in fast atrial fibrillation. Most of our colleagues that do cardiac MRI will tell us that it's just not an issue for them. And they get on with it, which is fine until you go back and you look at all of the original data that validated CMR stress perfusion, including the multi-center European studies like MR Impact 1 and 2, and most recently MR Informed done in the UK, and they all exclude patients with multiple ectopics and atrial fibrillation. So I think the person that asked that question makes a very astute point. Actually, we don't know what the best test is for our patients in AF. Well, that's my view anyway. So I've been asked to talk about, show you some cases for stress echo in patients that have aortic valve disease. There's a few things I'm going to talk about and a couple of things I'm not going to talk about that much. So I'm not going to talk too much, or I'm not going to show you a case anyway, of the use of stress echo in severe asymptomatic aortic stenosis. It's something that I think many of us have done in the last few years. It went out of the guidelines recently, and I'll show you why that was. I will show you cases of what we call classical low flow, low gradient severe aortic stenosis, so that's the patients with impaired ejection fraction. I'm not going to show you any cases of low flow, low gradient severe AS with preserved LVEF stress echo, so-called paradoxical low flow, low gradient, predominantly because the role of stress echo in this entity is still to be properly defined. I will show you a case of the use of stress testing in moderate AS patients that have symptoms, and also I'll finish with a case of aortic regurgitation. So, back in 2005, Lancelotti and colleagues published a study back in Circulation looking at the role of stress echo in patients that have severe aortic stenosis who claim to be asymptomatic. There were 69 patients in this study, and they performed bicycle stress echocardiography on them. They followed them up for actually a very short time period, less than 1.5 years, just 15 months on average. And then they looked at their endpoints or their outcome. And you can see the composite outcome here. And what you can see is that although a very small number of patients had what we would conventionally call hard outcomes, actually the main driver of the endpoint was referral for aortic valve replacement, which is of course highly subjective. These patients were managed by obviously an array of cardiologists and physicians. But nonetheless, they looked at their test and they showed that if your mean gradient goes up by more than 18 millimeters of mercury compared to rest, that appeared to predict that you had a bad outcome. And they produced this very dramatic looking Kaplan-Meier graph with two curves wildly separated, showing apparently a much worse outcome, although like I say, the outcome really that they were looking at was simply whether you were sent for surgery or not. So, a few years later, another group produced very similar data in a slightly larger number of patients. They looked at patients that had at least moderate, if not severe, aortic stenosis, with a mean peak velocity of just under 4 meters per second for all patients. And these patients also underwent bicycle stress echocardiography. What this study did, which was slightly different, was they looked at patients that had a positive stress test by conventional non-echo criteria. So patients that developed chest pain with ECG changes, patients that had a fall in systolic blood pressure, etc. And they excluded them. So they looked at the patients that didn't have that. And then they followed those patients up for just under 2 years. But once again, if you look at their endpoints, out of 67 so-called endpoints, 58 were simply being referred for surgery. So again, a very soft endpoint and a highly subjective one. But nonetheless, they found that if your mean gradient went up by over 20 millimeters of mercury on exercise, that you appeared to have a higher risk of achieving the outcome. And they also produced a similar Kaplan-Meier curve differentiating their patient groups based on rise in mean gradient with exercise. So on the basis of these two studies, in the 2012 ESC guidelines for the management of patients with heart valve disease, this test essentially entered the guidelines as a possibility, albeit with only a relatively weak 2B recommendation, an increase in the mean gradient of more than 20 millimeters of mercury in patients with severe asymptomatic aortic stenosis was considered a reasonable thing to do and a reasonable indication to then refer on for surgery. You will notice that in the latest guidelines, that has dropped away, and we are now back to conventional treadmill testing with the criteria of symptoms and fall in systolic blood pressure. So if you read this document in detail, it's quite clear that the reason that the stress echo component has come out of the guideline is because of the acknowledgement that the scientific rigor, I suppose, of the studies that were backing it was suboptimal, shall we say, and certainly the outcomes of measure were far too subjective to be endorsed in an international guideline document. So I must say in our practice in Southampton, I have stopped performing stress echo in this patient cohort. I still treadmill them regularly, but I don't perform the echo component anymore because I don't feel it really adds much to the treadmill component. So moving on to probably the most common indication for stress echo in aortic valve disease, which is low flow, low gradient severe aortic stenosis, first described way back in 1995. It's important to remember that there is a triad that you have to achieve on your resting transthoracic echo to meet the definition. Low flow, conventionally, has been thought to be synonymous with an ejection fraction of below 40%. Low gradient is the mean gradient of below 30 millimeters of mercury, and severe AS is a valve area by continuity equation of less than 1 centimeter squared. So you have to have those three components to be officially called low flow, low gradient, severe aortic stenosis. So the first thing that I would say to you all and urge you all is to make sure that you check the aortic valve area carefully. This was a patient that was referred to us for consideration of a stress echo. His referral was vetted and accepted without us really looking at the resting echo he'd had previously. So he attends for an outpatient stress echo. These are the parasternal images. You can see he's obviously got an abnormal ventricle. He's also got a calcified aortic valve. And these were the pulsed Doppler and continuous wave Doppler tracings. And I think there's quite a common perception amongst our non-imaging colleagues that if patients have impaired left ventricular function, then the gradients are going to be inevitably underestimated. Well, that may be true, but you have to look at what the actual resting echo shows. And this patient's valve area was very clearly and comfortably above 1 centimeter squared. So you don't need to perform a stress echocardiogram in this patient because this patient does not have severe aortic stenosis. So the first case I'll show you. This is a 78-year-old lady that had been admitted to our hospital in heart failure. Not our hospital, sorry, another hospital, and was transferred to us for consideration of aortic valve replacement. Her resting echo met criteria for low flow, low gradient severe AS. And the surgeons requested that we perform a low-dose dobutamine study to look into this a bit further. So essentially to try and differentiate between severe and moderate aortic stenosis. In all of the cases that I've got, I've sort of cut and pasted extracts from our formal reports so that you can see roughly what our reports look like. So you can see there the date and time of this study and her baseline data in terms of body surface area, body mass index, etc. So she had impaired left ventricular systolic function. Her quantitated biplane ejection fraction was just 27%. I won't go into the into this too much about the resting transthoracic images, only to confirm that she did have a poor LV with an EF comfortably below 40%. She had a mean gradient below 30, and her valve area was below 1. It was 0.83. Conventional dobutamine protocol, so starting with 5 micrograms per kilo per minute for 5 minutes, moving up to 10. The original paper just describes one stage, so just taking pictures at a low dose. I quite often find it helpful to go up to 15 as a maximum for a so-called mid-dose. I find that the trend in the data that you acquire is often quite helpful because depending on patients, sometimes there's not that much change at low dose. We used a quad screen to take images of the left ventricle as well. So on the left, you've got rest, and on the right, you've got the mid-dose. So you can then produce a table, essentially like this, with the various parameters, the Doppler parameters that you've measured at each stage, so rest, low dose, and mid-dose. And you can see on this patient that their LVOT VTI has increased from 11.5 up to 14.3, or if you were looking at stroke volume from 48 to 59 mils, that represents a more than 20% increase in the VTI. And you can see that the aortic valve area has stayed comfortably below 1 centimeter squared and has not actually changed that much. So unfortunately, we don't have a way of inserting a table into our reports. So our reports look like this, which is quite cumbersome, but actually this is a template that we have on Medcon. All of the numbers are actually just X's on our template, so we don't have to type this each time. We just fill in the numbers for each stage. And so then, of course, once you've performed your study, you have to issue a conclusion. And essentially, your surgeons will want to know two things. They'll want to know, do you think the aortic stenosis is severe, and does the ventricle have myocardial reserve or contractile reserve? So it was my colleague that actually did this test, and he's written here, LV function is severely impaired. There is an increase in stroke volume, and therefore flow reserve is present, and the aortic stenosis is likely to be severe. So this patient did go on to have surgery and did well. Next case, this is a 73-year-old lady, quite similar story, had been admitted to her local hospital in heart failure and transferred to us for consideration of surgery. You can see her resting echo data there. So she's got an LVOT VTI, which is very significantly reduced at just 13 centimeters. And as a result, her stroke volume is only 41 mils, so markedly reduced. Her Doppler data show very low gradients, as you might expect, peak gradient 20, mean of 12, and her valve area was below 1 centimeter squared. So she, again, meets the resting criteria for low flow, low gradient severe AS. This is her parasternal long axis on the left, showing you a calcified aortic valve and some images of her left ventricle on the right-hand side at rest. So she had dobutamine again, as per our standard protocol. We gave her low dose and mid dose, and we recorded the Dopplers at each stage and the LV quad screen at each stage. And what you can see here is that we were unable to change her stroke volume and her LVOT VTI. These remain fixed throughout. So actually we weren't able to normalize her stroke volume, which is, of course, the whole point of giving dobutamine to these patients. So our conclusion from this had to be that LV contractile reserve is absent. And of course, when you say that the LV contractile reserve is absent, generally we then have to conclude that means that unfortunately we're unable to distinguish between severe and pseudo-severe aortic stenosis because we've not been able to normalize transvalvular flow to see what the gradients are at that stage. Just as a slight aside, it is worth considering whether that is absolutely true. Is it genuinely true that we cannot comment on aortic stenosis severity in the absence of contractile reserve? I mean, there are certain things you can do. Some groups have advocated calcium scoring of the valve on cardiac CT, for example, as a way of looking at whether or not the valve is likely to be severe or not. But from a functional point of view, some of you that have heard me talk on aortic stenosis in the last few years will know that in addition to the indexed stroke volume, which is at the moment the most popular method of measuring flow, the transvalvular flow rate is also a very useful parameter, which is the stroke volume divided by your LV ejection time, and then multiplied by 1,000 to make mils per second. And actually, if you are able to normalize the flow rate, which you could do even in the absence of contractile reserve simply by shortening systole, because the heart rate goes up, so your ejection time goes down. If you're able to push that transvalvular flow rate above 200, you may be able to comment on this. And this is a concept that we first described just in a case report a few years ago. And then the Brompton group went on to look at this in a bit more detail in a case series of 42 patients published in JACC Imaging, able to demonstrate that actually in over 2/3 of these patients, you are able to increase the flow rate above 200, and you can then make a comment on whether or not you believe the aortic stenosis is likely to be severe or not. Now, this is still very much at the hypothesis stage. It's not in any international guidelines, but it's just something to think about, as we do sometimes come across these patients, and sometimes having some sort of other tricks that you might be able to use are quite helpful. Now, this was an interesting case. This was a patient that had high gradient aortic stenosis with a terrible ventricle. So this lady was admitted to our center. She was actually initially being considered possibly for a TAVI procedure. She was presented at the MDT. Her ejection fraction was awful. It was below 15%. But despite that, she had a peak gradient of 72, a mean gradient of 42, and a valve area that was very small indeed. You'll see on the next slide here how heavily calcified her aortic valve is. Have a look at that left ventricle on the left side, which is really not doing very much at all. So the question that we were asked was, does her left ventricle have any contractile reserve? And now there are some people that say, well, by definition, if you can generate a high gradient, you must have contractile reserve. I'm not entirely sure of the physiology behind that, and certainly our surgeons and interventionists were very keen to know that, that this ventricle had contractile reserve, given how poor ejection fraction was at rest. So, that's not going to play, is that again? Just give me a second, sorry. So we gave her dobutamine, rest, low dose, and mid dose. Actually, this was the first study in 2 years that I actually took written consent for, because I felt this was quite a high-risk thing to do, given how bad her ventricle was and severe her AS was. But nonetheless, these are her Doppler data at rest, low dose, and mid dose dobutamine. And you can see that her LVOT VTI nicely went up from 14 to 16 to 20, meaning that her stroke volume increased from 44 to 63 mils, associated with a normalization of transvalvular flow rate from 120 to 227, and her valve area obviously remains comfortably below 1. So we were able to reassure our team that yes, although her ventricle is terrible at rest, she does have contractile reserve. Her AS is clearly very severe. On the grounds of the bulkiness of her leaflets, she actually went for surgery. So, moderate aortic stenosis, 3.9 is apparently moderate and 4.1 is severe. I think we all know that, of course, it's not quite that straightforward. The reality is that we do sometimes see patients with moderate aortic stenosis that are symptomatic. It's always struck me as rather strange that when patients have chest pain on exertion, we exert them to see what's going to happen. Yet for patients to have symptoms on exercise with valve disease, we make our judgments based on their resting echo. Nonetheless, I'm sure all of you have seen patients with peak velocities across their valve of 3.6, 3.7, officially in the moderate range, yet apparently symptomatic. You can treadmill these patients. I'm not going to stand here and say that stress echo has to be done in these patients. I think treadmill testing to look at their exercise capacity, heart rate, and blood pressure response to exercise is a very useful thing to do. But I'm going to show you images from a patient that I've been treating just very recently, actually, in the last few weeks. This is a 66-year-old man. These are his echo images, not exactly conference quality, I know, but these are his images. He has normal left ventricular function. He has a calcified valve, which is relatively restricted. These are the peak gradients obtained. I'm sure some of you are looking at the thumbnail on that Doppler tracing thinking, look at that angle of interrogation, it's awful. Cosine of that angle is definitely not 1, is it? Well, yes, you're quite right, but we tried multiple attempts to get good gradients from the 5 and 3 chamber views as well as from the right parasternal, and I'm afraid that's as high as it got. So this is a patient that has no history of smoking, no history of occupational exposure to any respiratory pathogens. He's had breathlessness and has seen a respiratory physician and has had basic spirometry at this point, which was said to be normal. He has aortic stenosis, but he has a very clear history of deteriorating exercise capacity. He has dogs. Patients with dogs are usually quite easy to take histories from because they'll tell you about their walks and how much they're struggling with. So that was quite straightforward to understand. So we put him on a treadmill. He wasn't that keen on attempting a bicycle, so we treadmilled him. He managed 5 minutes. He only struggled to 5 minutes, really, of the standard Bruce protocol. So just after going from stage 1 to stage 2, he became breathless, which was quite interesting to see because he's otherwise quite a fit-looking 76-year-old. And we obtained some gradients at peak stress, as you do, both spectral pulsed wave and continuous wave. And so this is the data that we've collected. So he has a physiologically appropriate increase in both heart rate and blood pressure on exercise. His gradients go up, as you would expect, but if you calculate his valve area, for what it's worth, it remains comfortably above 1. He had no chest pain and no ECG changes during this test. So I'm still wondering after this stress test whether he's genuinely got significant aortic stenosis in terms of whether it's what's limiting him. So to try and get a little bit more information before I persuade my surgeons that they should operate on him, we did a TOE. His TOE wasn't the easiest actually in terms of imaging, but you can see his aortic valve there on the left-hand side, deep transgastric views on the right, to try and get some spectral Dopplers, which were actually very similar to what we obtained from transthoracic echo. You can crop this data set if you do 3D acquisitions on the machine itself, or we have TomTech software integrated into our platform, so I tend to favor doing that. So you can, sorry, this should play. So hopefully you can see that actually the aortic valve opening is really quite reasonable. And if you freeze that in the appropriate place and then do a 3D guided planimetry, this was coming up actually very similar to his 2D continuity equation as well. But nonetheless, he's gone on since then to have full pulmonary function tests and a CT, high-resolution CT. The respiratory physicians are absolutely certain his lungs are fine, he's not anemic, we have no other cause for his breathlessness. So I've referred him for surgery. And that's only a few weeks ago, so I can't tell you yet that he's better, but that's an example of when I've used stress echo for moderate AS. And then finally, AR. We don't really tend to do that much stress echo for AR. It's certainly not in the guidelines as something that we would do a lot of, but occasionally I find it helpful. Of course, whenever someone performs exercise, you would expect the ventricle to be hyperdynamic, and you would expect that the cavity size should fall on exercise. This is a patient who's in his early 50s. He's had a previous aortic valve replacement, so when he was in his 40s, he chose to have a tissue valve, did not want to take warfarin. That tissue valve has now failed, and he has severe AR. Claims to be asymptomatic and does not want to have an intervention yet, knows that or feels that if he can delay his intervention as much as possible, that would be advantageous to him. So he had a stress echocardiogram. This is his resting ECG. He did 12 minutes of the Bruce protocol, so a very good effort indeed. Didn't have any chest pain during that time, appropriate increase in his heart rate. That's his ECG at peak stress. So you can see markedly abnormal response to exercise. And his left ventricular cavity responded abnormally as well. His cavity actually mildly dilates, and his quantitated ejection fractions falls slightly. So certainly not a normal response. So although he says he's asymptomatic, we've, I think, been able to demonstrate quite clearly that his ventricle doesn't respond normally to significant stress. He hasn't actually changed anything. He still refused to have any treatment, but at least he's better informed now of the risks potentially of that. So in conclusion, I would say that stress echocardiography is a useful test in selected patients with aortic valve disease. We know that especially in patients with impaired LV function, it can help clarify the severity of stenosis. It can help clarify the presence or absence of contractile reserve. For patients with moderate AS, it can help give a clue as to whether or not that's likely to be their limiting factor. And for patients that have aortic regurgitation, seeing the effect of that increased preload on the ventricle with exercise can, in some cases, be helpful as well. Thank you very much.